So it's my great pleasure to introduce Anne Sloboda, one of the leading figures of music therapy in this country, but also active now as a psychoanalyst, covering so many fields that are relevant to our concerns today with a great authority. And her presentation today, Music Therapy for Patients with Treatment-Resistant PTSD. Thank you very much.
Thank you, Nigel. Today I'm going to talk about a clinical research trial that we undertook at the Guildhall School of Music and Drama, collaborating with a local health provider, the Institute of Psychotrauma, at that time based in the City of London. Part of it will be numbers, inevitably, as it's talking about a research trial, but I hope to move on as quickly as possible to talk about the human stories of the people involved in the research. I don't think this audience needs to be told this, so I'll move on quickly from that. The literature in music therapy has shown a lot of interest, increasingly, in the application of music therapy in psychological trauma. But until this trial that we did in 2008, there had been no randomized controlled trials, and little data gathered on the subjective experiences of patients, in that most of the literature talked about the experience of the therapists. These were the two organizations collaborating. The Institute of Psychotrauma in East London was very keen to explore arts therapies as an alternative treatment to the standard treatment that they offered, which was cognitive behavioural therapy. And the Guildhall School of Music and Drama, located very nearby, provides training for music therapists, which is what my job is. I head the master's programme there. And we wished to conduct clinical research and also explore clinical practice. But as we were a college working with students, it was very difficult for us to access any patients. So we collaborated together so that the Institute of Psychotrauma could come to the Guildhall, bring some of their patients, and we, who had the music therapists and the resources there, could trial it. And the purpose of this was to see if music therapy might have an effect on both the post-traumatic stress disorder symptoms of their patients and the depression which often accompanied it. Patients included in the trial all had a diagnosis of PTSD. They had all received trauma-focused recommended treatments, generally cognitive behavioural therapy, or had been offered it. They had all not responded to the treatment and had been discharged from the clinic, still suffering severe symptoms. The design of the study, very briefly, was that one group of people had 10 weeks of music therapy in a group, once a week on a Friday afternoon at the Guildhall. A second group spent that period of time waiting for treatment. And then following the 10 weeks, they then also had 10 weeks of music therapy. The treatment group were compared to the control group in terms of their symptoms. The control group's period of therapy wasn't evaluated, but it did provide additional treatment data, but it wasn't used in the research study. How the patients were selected. This was done entirely by the clinical psychologists working at the Institute of Psychotrauma. They invited a large number of people to take part, and eventually 17 men and women were randomly allocated to the two groups. They came from a range of different cultural and ethnic backgrounds. Their experiences were a range of trauma. Some had experienced torture, some had witnessed war atrocities, rape, had been victims of terrorism, and some had grown up in this country but had trauma here, such as childhood sexual abuse. And for all of these people, talking therapies had been refused or not properly used due to feeling shame, anger, or fear of the past, which meant they couldn't at that point make proper use of them. For all these people, it was very difficult for them to take part in the research study, which involved getting themselves to the Guildhall every week at the same time to take part and to be evaluated before the group with a questionnaire. Practically, many of them had a lot of practical problems. They were facing eviction, deportation, bankruptcy, and many of them had serious mental health and physical health problems. None of them had had any musical training before, so were pretty apprehensive about music therapy. They were very worried about getting around London, many of them, and that was a major symptom for a lot of the people. They felt frightened going out in public, they felt frightened using public transport, they felt frightened amongst crowds and strangers. However, they had become familiar and trusting of the clinical psychologists who worked at the clinic, so it was agreed that the best way to help them get to the Guildhall was meet them at the clinic, and the researchers would bring them. They were prompted by telephone calls, texts, and emails during the week to remind them to come, to encourage them to come. Several of them were highly sceptical about the relevance or usefulness of music therapy, but they agreed to give it a go. Just want to run through briefly the principles that inform music therapy in the UK. That wouldn't necessarily be true internationally, but certainly these characterise the way it's taught here. There's a great emphasis on relationships, either between the patient and the therapist, as you heard in the previous presentation, and if it takes place in a group, on the relationships between the group members. It's very important that anyone having music therapy does not need to have any musical training or skill. Improvisation holds a very central role. It was important in this work as well that people have the freedom to play, talk, or be silent. So participants in music therapy are not coerced into doing anything. And that therapists offer support and exploration through their clinical musical techniques. So the therapist needs to have musical skill and training, but the clients don't. I don't know if you can see this, it's rather small. But as this was a funded research project and needed NHS ethical approval, before getting this, we were required to produce a manual saying exactly what our treatment was going to consist of. This is quite a challenge for music therapists who have a very improvisatory approach and would not want to lay down exactly what they're going to do before the session takes place. Nevertheless, we managed to produce something that was broadly manualized but had built-in flexibility. So we said what we would do was therapists would facilitate members in starting to improvise, would listen closely to the participants' music, and when I say music, I mean any sounds that they might make, and accompany them. And of course, in a group, that's complicated because they may be making a great number of different types of music. But nevertheless, that would be the task. The therapist may discuss, describe, and draw out themes that become evident in the musical activity. They would encourage members to discuss their experiences and highlight shared themes or connections between members. And when I say experiences, I mean the experiences they were having at the time in the group. Nobody would be pressurized to discuss their traumatic experiences because it's clear that with this group of people, that was something they found very difficult. There would also be a group focus in that no one member would be singled out unless they wanted that. It's a rather blurry photo here, but it's just to show people who may not know what a music therapy room looks like, the setting that they were working in. Out of view, there were 2 pianos, and there's a mixture of percussion. The thing you can see in the foreground with metal bars is a metallophone, as Julie Sutton spoke about. There's a range of drums and other percussion. This is just quickly to show the process that people went through. A large number of people were invited to take part in the study. The ones that were eventually enrolled, as I said earlier, were randomly allocated to 2 groups. One group had music therapy with ongoing assessment in that they took part in a questionnaire every week. They had a follow-up interview and their data was analysed. And then the same thing happened with the group that had been waiting. Before they had music therapy, all the participants had high levels of post-traumatic stress symptoms, which were measured on the impact of events scale, revised, that's what those letters stand for, and their average score was 52. And as I understand it, the point at which they would receive a diagnosis would be 35. They also had high levels of depression, and their score on the depression inventory was 34. And while I don't want to dwell on numbers, this table just shows that the score for people having music therapy, that's the bottom line, decreased significantly after 10 weeks of music therapy. And it was certainly a bigger change than we expected.